Welcome to Health Talk. Today we have with us Dr. Paul Wang, Professor of Medicine, Director of the Cardiac Arrhythmia Service at Stanford University School of Medicine, Dr. Vikas Yalapu, Mary Gao. We are going to talk about atrial fibrillation, a big problem as all of us are having more birthdays. So, what is atrial fibrillation?
Well, thank you very much for the opportunity to be here today. Atrial fibrillation is a very important topic. It is a heart rhythm disorder which is associated with a number of medical conditions, in particular an increased risk of stroke. There also may be a number of symptoms that are due to atrial fibrillation. Patients may have reduced exertional tolerance. They may have symptoms that are very troubling that limit their activity. Shortness of breath, racing heart symptoms. So there are a variety of symptoms that may be due to atrial fibrillation. So it's very important that we make that diagnosis and detect atrial fibrillation in the population, the general public.
So when you say it's an arrhythmia problem, what does that mean for the home audience?
Yeah, that's a great question. So we kind of look at the heart in terms of its mechanical function as a pump, but we also look at the heart in terms of its electrical function. We know that the heart operates because of electrical signals that cause it to contract in a very orderly way. In atrial fibrillation, we lose some of that order, meaning instead of having a regular heartbeat, we get a very irregular heartbeat. And that, in addition to the potential that is a rapid beat, can lead to the symptoms and the other parts of the condition that I mentioned to you.
So what is the atrium? Here's the heart.
Great. So I'd love to tell you a little bit about the anatomy of the heart so you can see a little better. So as you can see, when we look at the overall heart, there are lower chambers and upper chambers. So when I describe this to my patients, I talk about a two-story building, meaning the atria are the upper story and the ventricles represent the lower story. And so when we open the heart, we can see that in fact these are the upper chambers, the atria, and the bottom chambers, the ventricles. The purpose of the atrium is to collect the blood, and then it goes down into the lower chambers, the ventricles, which ultimately pump the blood out. And so the atria play this very initial important function that help regulate how the blood flows. And so that's why a lot of the symptoms occur related to atrial fibrillation.
So Dr. Ilapu, you had many patients who have stroke, heart disease. What question might you want to ask Dr. Wang? This is a rare opportunity to have a cardiac electrophysiologist with us. Tell us. So what do you think?
Thank you again, Dr. Wu and Dr. Wang, for having me here. I had a question on, so what patient population is going to be more at risk for this type of arrhythmia?
Yeah, excellent. So really any patient can have atrial fibrillation, but we know that it's largely centered around ages 60 to 85. That's where the majority of patients in the U.S. population and throughout the world, they're centered in that area. There may be other conditions, particularly those of high blood pressure, that can also contribute to these. Some patients may have other conditions. Something called valvular heart disease is associated with increased risk of atrial fibrillation. There may be other forms of heart conditions. A weakened heart, something we call a cardiomyopathy, may be also associated with that. So there are some less common and more common kind of conditions. We may even look for non-cardiovascular conditions, so overactive thyroid, having disorders such as sleep apnea, for example, even metabolic syndrome, overweight conditions can be associated with an increased risk of atrial fibrillation. So there are a variety of things actually that are related to atrial fibrillation.
Mary, you had relatives, grandparents who had stroke. That affects, is a risk factor, or is it an end product of atrial fibrillation? So what happened to your grandparents?
Well, my grandmother had high blood pressure, I think probably from stress due to work, and then eventually she ended up having a stroke. So when should people be concerned, or how will they identify if they may have atrial fibrillation and they should seek the help they need?
Excellent question. So there are a number of different circumstances where the diagnosis comes up. So in many cases, the patient is truly asymptomatic. So they may come for a routine test. They're coming to have a procedure, and it's very common to have an electrocardiogram. And on the electrocardiogram, one may have the diagnosis of atrial fibrillation. So that may be what we call an incidental finding, something accidentally found. It wasn't the major purpose of doing the evaluation, but instead that's the result. In those cases in particular, we try to then determine what needs to be done about the atrial fibrillation, assess the patient, does any particular intervention have to be made. Ultimately, we use the electrocardiogram or some form of monitoring. By monitoring, we mean that someone will wear essentially a very miniaturized portable electrocardiogram. So these can be very small devices that are easy to wear, and that allows recordings to be made in everyday life. So rather than having it only be diagnosed in the office, we can then make this diagnosis of atrial fibrillation even when they're walking around doing their everyday life. And that allows us to capture the diagnosis of atrial fibrillation vastly more commonly than just having isolated electrocardiograms. And in doing so, we can then decide, does the patient need treatment or not? Regarding the issue you raised of stroke, we have an understanding now that certain factors that the patient may have, in fact, further increase the risk of stroke. So beyond having atrial fibrillation alone, which we know increases the risk, there are other factors which have a very large role. And the way we actually put those together is using a very popular scoring system. This is called the CHADS2 VAS scoring system. And by knowing your score, you can determine whether certain treatments are able to reduce the risk of stroke. So we look for those. Some of those include diabetes, prior stroke, hypertension, age, so 65 or 75, presence of vascular disease. Women, we know, also have an increased risk of stroke. And finally, congestive heart failure. Those are the most commonly used risk factors that then can be added in this score to determine, oh, is it appropriate to start anticoagulation, a certain kind of medical therapy that can be used to reduce the risk of stroke. So we really feel very strongly that identifying these patients is really important because, in fact, preventing stroke is our major goal.
Do you think that the estimate of 2 million people having atrial fibrillation is low? Do you think if there's more?
Yes, exactly. We think for a number of reasons. So one is that many patients are asymptomatic. They don't necessarily have an electrocardiogram. We know that, again, by having patients receive the diagnosis that they have atrial fibrillation incidentally. Even when people have done comprehensive studies in larger populations where everyone gets an electrocardiogram, we think that probably this is an underestimation at the present time. That increase in rate, relatively a rapid one, also occurs due to the fact that our patient population is aging so quickly. So as I mentioned, more and more people, in fact, reach the age of 60, 70, and 80 now. These are some of our fastest growing populations, portions of our population, and those are the ones who are most likely to develop atrial fibrillation. So we're expecting a very significant rise in the incidence of atrial fibrillation, possibly reaching 10 or 12 million in a number of years coming up.
Have there been any guidelines that have going to be applied for this aging population to see if a patient should get an EKG at a particular age going forward?
Yeah, great question. We generally haven't had a standardization in terms of electrocardiogram. It's something that certainly if patients have symptoms, that is something, again, we encourage them to seek attention. So one of the great things about this program is the general public sees this program and then can alert their doctor, oh, well, I have some unexplained symptoms. I have some shortness of breath or fatigue. Maybe that would be a good way, a good time to get an electrocardiogram, to update that, see their doctor. And so there are a number of ways in which the public awareness becomes very important in identifying those patients. Otherwise, we rely on kind of routine checks, as you mentioned, and that would be another way in which atrial fibrillation is diagnosed.
So once the patient's diagnosed, what is the treatment plan for the patient?
Great question. So when we look at treatment, we look at several different areas. So first, already I've talked about the risk of stroke assessment. So we generally do that and from the outset, since we know that's going to be based on the factors that we've talked about. The next big issue is the patient symptomatic from the perspective of the atrial fibrillation. That can be more difficult to sort out because the patient may come to us and say, oh, I'm a little more tired than I used to be. Well, when I go get the mail and go out and I'm a little more short of breath going down my walk or going up a flight of stairs. And so we have to determine, is it because of the atrial fibrillation or because of other conditions? Very often it is atrial fibrillation, and so it gives us some clues into the fact that it probably is leading to symptoms. And then we're allowed to then say, okay, if we can in fact improve the atrial fibrillation and treat it, we may be able to make the patient feel a lot better, have fewer symptoms, have less shortness of breath, and more energy overall. So we try to concentrate on that. The major strategies that we kind of look at are, one, what we call rate control. And so rate control is this pretty simple concept that in atrial fibrillation, the heart rate, that is when you feel the pulse, we call the ventricular rate, the rate in the lower heart chambers, when that gets very rapid, people are usually pretty uncomfortable and may lead to more symptoms such as shortness of breath. And by giving medications typically, just to slow down the rate, patients feel generally a whole lot better. Just really a very enormous degree of improvement. Then some patients really benefit from restoration of normal rhythm. That is, the amount of time that they spend in atrial fibrillation can be substantially reduced so that in fact they're in normal rhythm really all the time. So that becomes a very important goal called rhythm control, meaning that we put the rhythm back to normal. And in doing so, generally the patient returns back to their previous state and doesn't have the other symptoms that they had before that brought them to medical attention. So we try to determine really what the best strategy for each patient is. And that's pretty individual. So even though we have a stepwise approach we use, and that's generally accepted, we try to individualize for each patient. Is rate control adequate? Do they need to have rhythm control and that kind of thing? So it's a pretty, I would say, successful strategy, and one that we feel really results in patient betterment overall.
You said something about CHAD score. How can somebody get a CHAD score? And what is that? You explain to the home audience.
Oh,
CHAD.
great. So certainly assessing risk of stroke, it should be best made by a medical professional. So seeking your medical professional is ultimately the best strategy. But if people want to read about this, there are a number of great resources, particularly the American Heart Association website is the one I recommend to most of my patients. And that will give you a lot of information about assessing stroke risk and how to go about doing that. There's also resources for overall heart health on that website as well. So there are a variety of resources available to the lay public that I really encourage my patients to use and the general population at large. So there's a lot of information out there, but ultimately the decision for anticoagulation, that is the medicine to prevent blood clots, is going to be made in a very individualized discussion with your doctor, your healthcare provider.
So, during my rotations, I've come across a lot of patients who have certain bleeding disorders, and they're unable to take that anticoagulation from the CHAD-VASc score. Are there any newer drugs that are helping patients with those problems?
Yeah, excellent question. The situation where we feel that the patient is at increased risk to have stroke due to atrial fibrillation and therefore need the benefit of anticoagulation, but have overwhelming, what we say is contraindications to anticoagulation, that's a challenging situation. And by and large, that's been difficult in the past to handle. And largely, patients have gone untreated, and as a result, they really continue to have the stroke risk. So unfortunately, that's remained a pretty untreated group. That has changed more recently, and this is a rapidly moving part of our field, and new technology and devices are now available. One such device is called a left atrial appendage occlusion device. So if I could turn to our model again, a certain part of the left atrium, this front part here, is called the appendage. So it's an addition. It's like having an add-on to your house, an appendage area. That area in particular is important because it's felt to be the area from which most blood clots occur that cause stroke. So in patients that have an inability to take this medication called an anticoagulant, the ability to close off the left atrial appendage has been proposed as a potentially successful way to reduce the risk of stroke. And we're really in the beginning phases of being able to investigate and develop technology to do that. So currently there's several different ways in which you can close off the left atrial appendage. There is now an FDA-approved device that is, in fact, placed within the atrial appendage, and it essentially closes off this extra house, this area, and therefore has been shown to reduce the overall risk of stroke in patients with atrial fibrillation. So I think there are a lot of new technologies that we'll look forward to having in the future that will even do that probably even more successfully. But luckily, I think now we're having some alternatives for our patients that can't take anticoagulants because of serious bleeding concerns, but still have a very significant risk of stroke in atrial fibrillation.
So, Dr. Wang, I know you're the inventor of the cryoablation technique. Would you mind explaining to us what the technique is?
Great. Oh, yeah, delighted. So when we talked about different treatments for rhythm control, that is when we want to restore normal rhythm to the patient. So we think that the patient is symptomatic from atrial fibrillation. That is, they have these symptoms such as shortness of breath, fatigue, and we want to restore the rhythm back to normal so their symptoms go away. We look at medications typically first, but sometimes these medications either are not well tolerated or are ineffective in restoring normal rhythm. So there is a procedure that has been developed over the last 2 decades called catheter ablation. So what is catheter ablation? So catheters are little plastic tubes that are inserted into the body and then go into the heart. They're used to first make measurements within the heart, but ultimately go to the area of the heart, the aspect or the area of the atrium, which is most responsible for the atrial fibrillation. And so once they get to that area, they deliver energy, and that energy is what we call ablation, killing cells that are responsible for the heart rhythm problem. And that's this concept of catheter ablation. Currently, there are several different forms of energy that can be used to treat these cells or kill these cells that are responsible. And so one is something called radiofrequency or radio waves. So it's a special form of radio waves that can be used to heat up the tissue and kill these cells. But an alternate method called cryoablation is designed to freeze the cells and kill them in that way. And so there are different advantages in terms of each of the techniques as ways to treat atrial fibrillation. And these have been shown to be quite successful in treating patients who have atrial fibrillation and restoring sinus rhythm, normal rhythm.
Has there been any data where we know that either a particular ablation has been more successful in preventing recurrence of atrial fibrillation?
Great question. So there have been a number of different challenges in atrial fibrillation treatment. And in fact, some of our limitations are really the knowledge of understanding what causes atrial fibrillation has still been limited. And so we need to get to that point where I think we understand atrial fibrillation better. In addition, the tools that we have been relatively simple tools. As I mentioned, they're called catheters. They're about a yard long or so, and so they're relatively simple tools to be able to treat this condition, which is relatively complicated. And so having better ways to do that. And so one of the ways to do that has been to be able to develop tools that deliver probably a little larger area or a more tailored area to the patient's heart structure. And so that's been a very important aspect to be able to treat these patients. And so there's studies that now compare different techniques, such as I mentioned, radiofrequency and cryoablation, They seem relatively comparable. Some studies show maybe one benefit is better than the other, but I think they're roughly comparable, which means they have a fair amount of success. Now, what can be more difficult is for some patients that have more advanced atrial fibrillation, had it for a long period of time, and in fact may be fairly resistant to normal techniques. And so new techniques, surgical techniques, one we called hybrid surgical catheter ablation is one where we do use on many of these patients that have more advanced atrial fibrillation. And it's done by having a surgeon use very small little ports that are placed between the ribs and the chest and then are used to use a ablation technology that is from outside the heart. And then the electrophysiologist, the cardiologist specializing in arrhythmia, will go in through using catheters to be able to touch up the areas and complement what's been done there. And the success of that may be higher and is likely higher in patients that have this more advanced degree of atrial fibrillation, for which catheter ablation probably is less suitable. The other major advance is that of finding where these locations are most critical. And one of my colleagues, Dr. Sanjeev Narayan, has developed one of these tools. And this is called firm or focal impulse rotor modulation. And the concept there is that there are specific areas that we've never really been able to identify previously. That is, we think, okay, there are different parts of the atrium that are for sure required to be treated in atrial fibrillation in ablation, but we really can't identify all of those. And so what we now have is a way to be able to essentially have a tool to see the electrical pattern in a different way that will guide us to these areas that otherwise we would say, gee, I wouldn't know how to identify this area versus this other particular area in an individual patient. It's been largely, okay, these sets work for most patients, but how do you individualize? So it's really an ultimate aspect of personalized medicine that you've heard about, people talk about in the national news, is to be able to tailor to the patient a specific set of treatments. And so this is one very exciting area where we really hope that adding our knowledge of atrial fibrillation and figuring out exactly how it works can lead to better outcomes. And so we're very excited about the future in developing new strategies for treating atrial fibrillation.
If people fail Coumadin or don't like it because they can't eat salad, what is the next line of new anticoagulants that are not Coumadin-like?
Yeah, great question. So there are now a whole family of medications that are all considered anticoagulants, meaning they prevent stroke quite successfully in patients such as having atrial fibrillation. And there are a number of them now. And the advantages that you mentioned, they do not have the same drug or food interactions as we see with warfarin or Coumadin. And so that allows the patient to be freer in their diet, less concerned about these other medications in many cases. And so there's I think, a much greater ability for many patients to take these medications. One of the things that is being developed, which is particularly going to be helpful, is if the patient who is on one of these medications has the need for emergency surgery, for example, the ability to reverse these agents rapidly now is emerging. So there's one medication that's developed to reverse one of the new agents, and now we expect in the hopefully next year, there'll be another medication that will be released that will be able to reverse the other medication. So we have a lot to look forward to, a lot of advances in this kind of therapy, so that I think the majority of patients now who need to have anticoagulation therapy to reduce the risk of stroke, that they will be able to take it. There won't be the concern about a lot of these issues. So we're really hopeful that the risk of stroke due to atrial fibrillation will continue to decrease very significantly.
To wrap up, what is the take-home message you would like our home audience to have? Like, what is it to watch out for, when to see a cardiologist, and...
Great. Yeah, thank you for that question. So some of the things we like to consider is, one, as I mentioned, if you have symptoms that are unexplained, so you ask either yourself or a family member, you have unexplained fatigue, shortness of breath, chest discomfort, you should be seeing a medical professional. And they may, as necessary, refer to a specialist in either arrhythmias or in cardiology, and as needed. And they will be able to make the diagnosis. And as I mentioned, the other take-home messages, an electrocardiogram can be useful. And in some patients, specialized electrocardiographic monitoring may be useful. Some kind of recording device, yeah, exactly. And there are many very easily wearable devices now. The next point would be that of anticoagulation and stroke. So again, family members who do have atrial fibrillation, we should ask, should they be on anticoagulants or not? And finally, there are now new treatments such as catheter ablation, medications also, but treatments that can improve the lifestyle of patients that have atrial fibrillation.
So to summarize, it's very important for the home audience, if they have symptoms of shortness of breath, feeling dizzy, passing out, rapid heart rate, there's also triggers. Cold drinks may trigger it, hot drinks may trigger it. To see their primary care doctor, and maybe be referred to a cardiologist, and to get an EKG. So if you have symptoms, get an EKG. And to check in with your PCP for your regular exam. And for all those who take care of family members on warfarin or Coumadin, if they don't like it, there's a new set of anticoagulants. And so thank you for joining us. This was a great discussion about atrial fibrillation, affecting 2 million people in America, expected to grow, slightly maybe underdiagnosed, and to really go to the American Heart Association website to find out more information. American Heart Association, and think about stroke awareness. Thank you very much for joining us. If you like Health Talk, if you like KSAR, please make a donation to KSAR TV, Saratoga, California.